People with a diagnosis of BPD often face a lot of prejudice in society and also from healthcare professionals. Personally, when I received my BPD diagnosis by a doctor I never met before and would never meet again, I was offered no help for my new diagnosis and no real exploration of what this life-changing news meant. The next I heard about my diagnosis was when I received a sick note with a diagnosis for EUPD on it. When I flagged up how this new diagnosis had been communicated with me and the lack of support I received for either diagnosis, was made to feel like I had nothing to be upset about and was shamed for mentioning it. I was made to feel like I was being difficult and overly emotional, both stereotypes for people with BPD. The 2003 report titled "No Longer a Diagnosis of Exclusion" discovered the poor treatment of those diagnosed with BPD by the NHS. We are often painted with the same brush, as being manipulative and attention-seeking for serious things like self-harm and suicidal ideation. Those whose role is to support us with our health are instead sometimes causing more harm than good. Many experts, mental health activists, and people with lived experience of mental health have come forward to raise the same concerns about the rollout and expansion of the high-intensity network, which includes the Serenity Integrated Mentoring. It is for crisis care, combining NHS services with the police force on an institutional level. Often these high-intensity users have serious trauma, mental health problems, and behaviour disorders. Within Serenity Integrated Mentoring, a mental health professional responsible for the clinical elements and a police officer responsible for the behavioural side and community safety team together to support each patient with things like identifying coping mechanisms. It has been called unethical, unlawful and unsafe, as it actively encourages people to be denied vital support. Within the new SIN, NHS services are encouraged to turn away patients who frequent A&E, critically limiting support options for some of our most vulnerable members of society. It advocates withholding essential treatment, whilst giving police a key role in making often life-changing decisions. The Stop SIM Coalition, a group of mental health service users and allies, believe that this initiative is in breach of our fundamental human rights. The Human Rights Act claims we have the right to life. This can be breached by policy decisions which undermine or threaten someone's life. By withholding treatment or encouraging people not to use life-saving services, they have given doctors and nurses the confidence not to treat patients. The Stop SIM Coalition also have found it to be a breach of the Equality Act 2010. This is because SIN response plans encourage limiting care, such as access to X-rays or blood tests. This is discrimination based on disability. In the past, a senior judge said the discharge of a young girl, after there were no hospitals, leading to her committing suicide, left blood on our hands. BASW is concerned that most supporting evidence for high-intensity networks and Serenity Integrated Mentoring is very limited, and there is a clear lack of co-production in the design and delivery of these services, meaning that those who need it have not been given a role in the creation. This is despite the high-intensity network stating we are experts of our own care in their 3 core principles. Instead, it's based on cost reduction and financial savings by encouraging NHS staff not to treat patients. The National Survivor User Network agrees with this assertion, also claiming it focuses on demand and staff time. Thus the focus is not on the well-being of mentally ill patients. No high-quality research into the impact on service users. At least it is promising to see staff welfare being taken into consideration. The creator of SIM is ex-police sergeant Paul Jennings. He claims that the unsustainable demand on our NHS services lies in overdependence and behaviour issues rather than underfunding and inequalities. Ultimately, the patient's right to self-determination is massively decreased as the amount of places to turn continues to wane. Even more responsibility is put on patients, especially those who are isolated, as it actively encourages people with personality disorders to take responsibility for their distress and do the work trained professionals should be doing. For those lucky enough to have good support systems, it puts more pressure on friends and families to do the role that in the past NHS services would have done. A leaked document of staff comments from the original SIM pilot show the cruelty of NHS staff towards service users. This includes support for scaring users into not repeatedly contacting the service for help. The same document shows support for police coercion. SIM is designed for people who have not committed a crime, but by involving the police in mental health care, it is inherently criminalising illness. The police's role is in its own works coercive, a form of behavioural management. Users can be threatened with prosecution or prison if they continue asking services for support while struggling with their health. The director of the user-led charity Wish points out suicide has been criminalised. For example, people have been imprisoned or fined for attempting suicide. In fact, SIM targets women as the most high-intensity users with histories of sexual abuse or violence. A similar trend can be seen with BAME members of the community. It disproportionately impacts ethnic minorities as black people are overrepresented in detention centres and therefore will be disproportionately within SIM, which recruit service users partly based on repeat detentions. Statistically, BAME people are less likely to approach healthcare services when police and government agencies are involved. They are also disproportionately subject to physical restraint and covering forms of treatment. A spokesperson for Black Lives Matter said the police have no place in supporting black people or any people in mental health crisis. The sharing of records between mental health services and the police invites more state surveillance into our healthcare system and make seeking support actively unsafe for black people, sex workers and other marginalised groups. There is research into how people within oppressed groups are often overdiagnosed. LGBT groups are often wrongly given a diagnosis for BPD due to lack of education and knowledge of LGBT issues. Often a gut-feeling approach is adopted when it comes to diagnosis. This causes long-term damaging. Around 90% of queer students grow up hearing slurs directed at them. This combined with other issues which can disproportionately affect LGBT plus people, like childhood trauma, lead to a sometimes wrong diagnosis. Therapist Patrick A. Rowland: if society mistreats you your entire life and makes you feel different or less than, acting out behaviours similar to impulsivity and lack of boundaries common to BPD makes sense. People may lack self-esteem due to disrespect by the larger society and have less stability.